complex regional pain syndrome type 1 or reflex sympathetic dystrophy. General considerations. The syndrome is characterized by burning or aching pain in an injured extremity, which is more severe than would be expected given the inciting trauma. It occurs in all age groups and equally in both sexes and can involve either the arms or the legs. The degree of trauma is in some cases surprisingly minor, phlebotomy, but most cases follow crushing injuries with lacerations and soft tissue destruction, closed fractures, simple lacerations, burns, especially electric burns, elective operative procedures, and myocardial infarction with referred left arm pain or other reported causes. Clinical findings. In the early stages, the pain, tenderness, and hyperesthesia are localized to the injured area, and the extremity is warm, dry, swollen, and red or slightly cyanotic. With time, muscle spasm and joint stiffness limit mobility, and the nails may become rigid. In advanced stages, the pain is more diffuse. The nocturnal pain may become extreme. The extremity becomes cool and clammy and intolerant of temperature changes, particularly cold, and the skin becomes glossy and atrophic. The patient dominant concern is to avoid external stimuli, particularly in trigger point areas. Pain and disuse lead to loss of function. Radiographs reveal asymmetric osteopenia more severe than anticipated from immobility alone. Osteopenia, osteopenia, osteopenia. Prevention. Trauma to peripheral nerves during surgery is avoided by knowledge of their anatomy and careful mobilization by handling the perineural tissue only. Splinting and adequate analgesia followed by early mobilization of an injured extremity minimizes the occurrence of reflex sympathetic dystrophy. Treatment and prognosis. Conservative measures. Early recognition and treatment are essential to preserve function of the limb in the early stages when major secondary changes have not yet developed. Physical therapy is involving active and passive exercise combined with a mild anxiolytic, diazepam 2 mg twice daily, or alprazolam 0.125 to 0.25 mg twice daily as ordered by the doctors, may relieve symptoms. Opioids have been a mainstay of treatment. Recently, however, gabapentin has been used with success. Sympathetic blocks. Stellate ganglion or lumbar can be combined with the intensive physical therapy for cases refractory to more conservative treatment. Protection from further injury and avoidance of irritating stimuli are imperative. Surgery. Patients who achieve significant temporary relief of symptoms after sympathetic blocks may be cured by sympathectomy. With advanced disease and in cases with significant psychologic overlay, however, the prognosis for improvement with sympathectomy is poor. Implantable spinal cord biostimulator devices have had limited success. Thank you.